I'm the MC of today. There are 2 days of conference. Today is the first day, and it's placed at Olympus T-TEC, Thailand. And there are the on-site participant and also the online participant in Zoom broadcast. And the next day, we will move to Pattaya Pat Building, Chulalongkorn Hospital. Short briefly for today, in the morning, we will present you many interesting lectures from experienced speaker. And there are 2 sessions in the morning, and we are talking about many endoscopic diagnosis and therapeutic techniques. And at the break time, we will have a picture together in front of this room. And in the afternoon, we will attend endoscopic workshop just only for the on-site participant. And if anyone has any question, please don't hesitate to ask our speaker. And for the online participant, you can type it in the Q&A box. And for the on-site participant, there are like a Q&A session after each period. Upon this time occasion, it is now my great pleasure to introduce APELS Chairman, Professor Michael Lee from Hong Kong, Director Minimally Invasive and Robotic Surgery Development, Hong Kong Sanatorium and Hospital, Hong Kong. Please welcome.
Good morning, ladies and gentlemen. Welcome you all to our 8th course of endolaparoscopic surgery training in upper GI. This is the 10th year of APELS, so we've come a long way from when we first started, and by a group of enthusiastic surgeons who wants to train the future generation of surgeons doing endolaparoscopic work. I guess you are very lucky to be chosen for this course because there are a high number of applicants. So enjoy your 2 days program here and intermingle with each other and to share your camaraderie, because maybe in a good 5-10 years time, you'll be back here as faculty. Now, without further ado, I would ask Professor Sim and Professor Suthep to start the meeting. Thank you.
Next is a course introduction by our course director. The first one is Professor Suthep Udomsawaengsup, Professor of Surgery and Program Director, Department of Surgery, Faculty of Medicine, Chulalongkorn University. Please welcome.
Thank you, Tanandon. Thank you very much, Professor Lee, Professor Ria, and Professor Yip. Ladies and gentlemen, thank you very much for coming, joining us. First, I would like to thank APELS for the power that we'll be sharing to you. I know that this is the 8th APELS, the international workshop here at T-TEC, and tomorrow we continue at King Chulalongkorn Memorial Hospital. As our chairman has been mentioned earlier, that you are the one who will be selected to be continuing the genetic from APELS. So today you're learning not only the technique and knowledge, but also the culture that Professor Lee has been initiated and continue to be, transferring to you. This is about the heart of, sharing and contributing. So hope you will be enjoying today's workshop, and in the future for sure coming and share your expertise here as a faculty. For example, you can see as our course director, Dr. Kanogan and Dr. Panpat, they used to be sitting probably your seat, and now she's in charge for the course director. So that's what we are, the APELS, been doing. So ladies and gentlemen, once again, I would like to thank Professor Lee and also Olympus, as well as Medtronics. So I hope you enjoy today's academic package that we providing to you. And tomorrow we'll be welcoming you at King Chulalongkorn Memorial Hospital for the cadaveric lab. Thank you very much.
I would like to introduce you another course director of this program, Associate Professor Asim Shabir, Head and Senior Consultant, Department of Surgery, National University Hospital, Singapore. Please welcome.
A very good morning to all of you. To all the dear participants, I'm delighted to learn and very glad to see so many upper GI surgeons in the room. You are the future of Asia, and we welcome you to APELS. As Professor Michael Lee and Suthep already pointed out, you are our future. Today you sit in those benches, tomorrow you will be in the benches in front of us. And that's what we want, and that's why you are here today. It takes visionary thinking to form such organizations, to propagate the most important thing that human culture has seen, which is education. And hats off to Professor Michael Lee and his team who put together this APELS with the vision to promote something, a tool that we had left behind and moved on into laparoscopy, to bring back endoscopy, combine it, and complete us as a surgeon. So endolaparoscopic surgery, the primary theme of this meeting is there. I would be very unfair if I do not say words of gratitude to my team. Hon-Chi, Kanoka, and her team, including Kadora, have worked tirelessly to bring this to you, all right? If you open my handphone and look at the number of messages that we have exchanged, I think they're just exorbitant, some of them which I might have not even read, all right? So hats off to these people who've actually put this together, and to Olympus for actually hosting us here, Medtronics for providing the support, and to all of you participants. Without all of you, this meeting would be meaningless. Right? So I hope and I do expect you will do justice to the workshop by learning and bringing experience back and serving the population you deserve to support. Our team, including Professor Michael Lee, Suthep, myself, and the rest, are always available anytime during the course and even after that to support you. So welcome once again, and thank you very much.
I would like to invite Dr. Asim to be a moderator of the next session. It's a very interesting lecture from our experienced speaker. Please welcome.
Hello, thank you. So if you think my job was easy, it's not easy. And I'm the first one to sit on the chair in the morning, and I have to conduct the meeting. So welcome once again. Thank you very much. We'll begin our session 1. And this session is largely going to look at basics in endoscopy. And first of all, it's my honor to invite clinical assistant professor and honorary associate consultant from the Division of Upper GI and Metabolic Surgery, Dr. Hon-Chi. Hon-Chi, as you know, is the co-director of this and the co-chairman of this meeting as well. He's put in a lot of effort. I've always known his unit to be the leading unit of endoscopic interventions in Asia. For many of you who do not know, the Apollo device came from Professor Sidney Chung from the same unit, and they are very progressive in their work. So he's going to speak to us today about basic principles of imaging enhanced endoscopy. Hon-Chi, the stage is yours. Thank you.
Thank you, Asim. And once again, thank you so much, Professor Michael Lee, Professor Suthep, Kanokan, and Professor Asim, for the kind invitation to join this very important APELS meeting. So, echo to what they said, a few years back, I probably was somewhere upstairs listening. So it's really my great pleasure, and I do hope that in the future, maybe someone in the audience will be standing here and teaching the next generation, and we will spread our laparoscopic techniques to future generations of surgeons and endoscopists. So today I will start with a very simple introduction, and then we'll have even more fascinating lectures by our subsequent speakers. So I will just talk a little bit about what is image-enhanced endoscopy. So basically, it's a very wide variety of modalities of endoscopic techniques using different technologies to create a better contrast, resolution, or magnifications. In the past, it's mostly for diagnostic purposes, but recent developments has allowed this IEE image-enhanced endoscopy to be used for therapeutic use as well. And we have even newer generations of endoscopic systems that will help to improve therapeutic procedures. So if you look into the variety of IEE, it could start from very old style dye-based chromoendoscopy, and then you have equipment-based digital or optical devices such as the NBI. We all probably know it very, very well. And you may also see cellular level images with the newest technology provided by our endoscopic companies. So for chromoendoscopy, I will just briefly go through it. So basically, it's the use of dye spraying so that you are able to enhance the tumor characteristics and improve the diagnostic characteristics. It's a very old technique. So back in 1970s from Japan. So you can broadly characterize all these stains into contrast methods, absorptive methods, or reactive methods. So we start from contrast methods. So contrast method is the technique where you basically just pull the contrast into the depressed area so that it highlights the surface topography. So you can see in this example how after adding indigo carmine, the lesion borders and the characters is being highlighted very nicely with just a simple spray of some contrast of indigo carmine. The other method is absorptive method. So these dye will actually be stained in the epithelial cells, preferentially across the cell membrane. So this includes methylene blue or crystal violet. So these are more commonly used maybe in the colorectal field where the mucosa is readily absorbing crystal violet. So crystal violet chromoendoscopy is also very commonly performed for colorectal procedures. Acetic acid is one of the very popular dye that we use for upper GI, maybe more in esophageal or junctional cancers, just to highlight the area of abnormalities by an absorptive method that will whiten the epithelial surface for better characterizations. So reactive method, again, very commonly used in upper GI, so including Lugol's iodine. So you can see how this early esophageal squamous cancer has been highlighted by the Lugol's iodine, because the Lugol's will react with the cells of the epithelial cells. And those areas that do not stain will be the abnormal area due to the cellular dysplasia, etc. So roughly, you can see that all the different dyes that are commonly used can be used in various locations of our GI tract and can be used for detection as well as characterizations. Of course, you need to be careful about the preparation, so you need to know the concentrations, because different concentrations, for example, for indigo carmine, if you use different concentration, you may have different effects. So if you're using a thin dye, you can see a global assessment. And if you use a thick dye, you'll be able to see a magnified assessment of these lesions. So you may choose different concentration based on your need. The same with Lugol's iodine. So nowadays, we prefer to use a lower concentration, better to be less than 1% or maybe at most 1%, because the higher concentration, the higher is the risk of chemical esophagitis or reactionary symptom that the patient might experience. So it's better that we are able to use a lower concentration of dye for iodine solution. So you can spray it, you can use a syringe flushing so that you can apply it better. But more importantly, I think in recent years, we have different types of electronic or device-based image-enhanced endoscopy, for example, NBI. So allow me to share with you what NBI means. So narrowband imaging, basically, it's how you look into different colors. So for example, if you shine white light onto an apple, because the green and blue light will be absorbed, so your eyes will interpret it as a red apple. On the other hand, if you shine only blue and green light onto an apple, what happens is these two lights will be absorbed. there's nothing that will reflect onto your eyes. So your eyes will interpret it as a black apple. So this is the basic of what's so-called selecting specific light wavelength of light to enhance the appearance. So if you shine blue light onto the surface epithelium, basically what you will see is most of them will be reflected. Some of them will be absorbed into the capillary because blue lights penetrate very low, and they would not go into deeper venues or deeper capillary veins. So all you can see is the very superficial capillaries in a very high contrast. So you can see them very well. Green lights has slightly higher penetration, and it will similarly, some of them will be absorbed in the capillary level, but partially penetrating. They will also go to the deeper venues, so that you will also see some of the area of the deeper venues. So that's why you will be able to see both some of the venues as well as the capillaries. However, if you use a red light, so what happens is basically everything will go penetrate, and then you will be able to see very poor contrast of our surface epithelium because the light is so strong that it will go through all the structures, and you will only be able to vaguely see the deeper veins in a low contrast. So basically, this is what you'll be able to see. So with blue lights, you focus on the superficial areas. With green lights, you're able to see slightly deeper some of the venues, but then the capillaries is still quite readily seen. If you use red light, you can't see anything except the deeper venues. So this is the basic why we try and use NBI, because it will highlight the surface structures, the surface pattern, vascular pattern for diagnostic purposes. So of course, sometimes we also, during therapeutic procedures, we may also consider using it under liquid or even gel or under water, because with water, you will have a higher percentage, so you will have a magnified view of 1.5 times, and you will have a very good visualization. There are also some recent development of other gels that will help to enhance the view, even during therapeutic endoscopy. So I will skip this video, probably. So this is how it will look like underwater, but I think because of time, I will skip. So in recent years, there's a even newer generations of devices from Olympus company. For example, the TXI, so which is actually texture and color enhancement. So by separating the texture and the color through the endoscopic system, they are able to enhance both the color and the surface. So this is a good potential that it will highlight early lesions easier, so that we are able to detect all these early cancers. So there has been studies showing that the mucosal atrophy or gastric neoplasm seems to have a better visibility score with this new modes. And indeed, there has been a recent randomized phase 2 trial published by the Japanese group showing that the TXI as well as the third generation NBI has a very good ability in terms of detecting early cancers. So the third generation NBI, of course, is very, very good. And the TXI is also one of the promising techniques. So we'll be eager to know the detail what these new technologies will bring us in the future. So the third technology is RDI. So RDI is another different new technology from the Olympus company, where there is an addition of amber light. So amber light is a special light that is highly absorbed by hemoglobin. So normally, if you shine all these lights into the mucosa, so green lights reflected or absorbed, amber and red light will be reflected. So this is how it will look like. But if there's a vessels, then this time, green light will also maybe absorbed and only slightly reflected. Red light penetrate through, and the amber light will be largely absorbed by the hemoglobin inside the vessels. So because of this special feature, then you can actually see the structures inside in the deeper veins in even a better contrast. So these are the examples of TXI and white light and NBI. And this is what you can see with the RDI. So you can see highlights of deeper area of the vessels because of the absorption of the hemoglobin. So the particular use of RDI is when you're having trouble with bleeding. Because as you can imagine, when there's bleeding, there's a lot of hemoglobin around in the bleeding sites. So the area with the highest hemoglobin concentration, that is the bleeding point, will show by the RDI because of the darker color being absorbed by the amber light. So imagine this. So the amber light shining into a pool of blood will show the area with the largest bleeding, the active bleeding site, because of the absorption of the RDI, of the amber light. So just an example of a video that will show how it does work. So this is a patient who is undergoing a POEM procedure where there's a bleeding. So maybe it's still easy to see if you have enough experience, but then changing to the RDI, then you can see clearly the highest concentration of blood by the color difference at the bleeding sites. And then you can precisely grasp it with the coagulation forceps so as to control the bleeding by this changing to the RDI mode. So for endoscopists or maybe for gastroenterologists, they're not used to a lot of blood. So they find it happier if they don't see the red. So maybe less for surgeons. So anyway, but this is one of the real new technology that we're seeing. So there are many potential use of RDI, including bleeding points for acute bleeding, submucosal vessels during POEM, and maybe even during ESD when we are encountering bleeding. So just finally, a short note about cellular level imaging. So, so we have been seeing higher and higher technology, and this is one of the example where we can actually see even higher magnification of our tissue inside the GI tract. So this is the endocytoscope, also from our Olympus company, that has a magnification ratio of 520 times. So for example, if you look into the mucosa of the stomach of intestinal metaplasia, you can actually see, just by using ultra-high magnification MBI, you can see all these structures of high magnification, including the epithelium and vessels, and you may even see some of the goblet cells that are very commonly seen with the metaplastic mucosa. So this is a non-dye base. But if you want to see even better, the cellular imaging or cellular level assessment, this is what is potentially seen. So this is an early gastric cancer focusing on some parts. By spraying some dye, you're now becoming somewhat like a cytopathologist with the use of methylene blue and crystal violet combining and staining onto the cell. You can actually see nucleus and you can see cytoplasm. And by seeing the cellular atypia or cellular structural change, you can actually predict the histology. So you can see how these two slides have some similarities in terms of the cellular atypia and nuclear abnormalities. So, so I would just like to say in the end that IEE has become one of our standard techniques in observing the GI tract with a wide variety of applications in both diagnostic and therapeutic endoscopy. And we are seeing exciting new modes from our endoscopic systems that may be reducing the need for a conventional dye-based image enhancement. So with that, I would like to conclude my talk. Thank you so much.
Thanks, Hon-Chi. We'll keep the questions to the end. We have a 15-minute session. Thank you very much. It's my great honor to introduce our next speaker, Associate Professor Prasit. Associate Professor Prasit belongs to the Department of Surgery, Faculty of Medicine, Thammasat University. He's the president of the Thammasat Medical Alumni Association and part of the Research Committee, Royal College of Surgeons of Thailand. Dr. Prasit will be speaking to us about detection and characterization of early esophageal cancer. Dr. Prasit, please. Thank you.
Thank you very much, Professor Asim. Professor Michael Lee, Professor Suthep. The next section, I will talk about the detection and characterization of early esophageal cancers. the topic detection and characterization of early esophageal cancers. Today, the topic will talk about the early esophageal cancer with detection and the diagnosis of the invasion depth. For the esophageal cancers, in Global Can data 2020, the new case of esophageal cancer ranking on the 8th and the dedicated ranking on the 6th. If you face to the advanced case, the patient have to do the surgery and have the risk of the morbidity and the mortalities. The early cancer is the one of the way to make the patient can cure. And definition to make the understanding when you talk about the early cancers. The first one is superficial cancers. WHO have the definition of the superficial cancer that the lesion located both of the mucosa and the submucosa that might be with or without metastasis. And early esophageal cancer is the clinical useful term. That means the cancer can curative. And the meaning of the early cancer is the local lesion which has no risk of the lymph node metastasis. If you see this the esophagus from the endoscopic view, can you recognize the lesion? It's no, because you see like the mucosa and the water inside the lumen. You can see the mucosa really visibility may better after you clean the mucus. You can see the left side, you see the red area, and from the NBI, you can see the difference of the mucosa area. For the first of the endoscopy, you can see the lesion by the white line endoscopy. That the lesion you can define from the macroscopic finding as we call the Paris or Bowman classification. From the type 0 in the left side, that means the lesion located on the mucosa and the submucosa. But from the type 1, 2, 3, 4, that means the lesion invade to the muscularis propria, that means the advanced cases. For the type 0, we divided in two types. One is a polypoid and another one is a non-polypoid lesion. For the Paris classification type 0, you can see the type 0 to B, the depth of the invasion mostly located on the mucosal layer in M1 and M2. For the image enhanced endoscopy, as in the sample of the case use the NBI. You use the NBI with the high resolution endoscopic imaging. You can see the difference of the color of the area of the lesion. For the magnifying endoscopy, the magnifying increase the magnification 80 to 120 times. And if you use the magnifying endoscopy with the NBI, you can see the vascular and the surface structure well. For the diagnostic performance, using the white light comparing to the magnifying endoscopy and NBI, if you use the magnifying endoscopy with NBI, they increase the sensitivity and the accuracy for detection of the cancers. This is the sample case, 3 cases in my experience. In the left side is the first case, second case, and the third case. And in the upper borders, this use the white light. The next one is NBI, and in the last of the slide, you can see the NBI with magnifying endoscopy. The other technique for the detection, we use the local solution that the iodine will have the reaction to the glycogen. The glycogen is the storage of the energy. If the cell have the transform to the high grade or cancers, they use the energy from the glycogen. After we spray the iodine, that can see the iodine unstaining area, that means the lesion might be low grade or high grade intraepithelial neoplasia. If you use this method from white light, NBI, and chromoendoscopy with local solution, comparing to the three modalities, using the NBI and the local solution increase the sensitivity for the detection of the cancers. The lymph node metastasis is the very important factors because of the factors that make the cancers have metastasis. The first one is the depth of invasion, the lymphatic invasion, histological grade, and vascular invasion. That are the most important for the principle of ESD and the important for select cases for the endoscopic resection. For the early esophageal cancer, we detection the abnormal area and can define the depth of the invasion by intraepithelial capillary loop that we call the IPCL. We use the IPCL with the magnifying endoscopy plus the NBI. And for the Japan Esophageal Society has defined the IPCL pattern to type A, type B. For the type A, you see in the pictures is no vascular morphological change. For the type B1, you can see the loop-like abnormal vessel with dilation and tortuosity, auricular diameter and shape. For the B2, you can see the abnormal vessel with poor loop formation. And for the B3, you can see the thick and greenish abnormal vessels. From these abnormalities, the others to define the depth of the invasion is the avascular area. If you see the avascular area that divide to small, middle, and large, the small that mean the lesion has depth into M1 and M2. The middle that mean M3, SM1, and the large of the avascular area that mean the depth of the invasion, the cancer invade to SM2 and SM3. For the magnifying endoscopy classification of Japan Esophageal Societies, the B1 vascular structures is very important because if you see the B1 type of the IP cell or the avascular area small, that means less than 0.5 millimeters, the depth of the invasion of the cancer located on M1 or epithelial or M2 on the lamina propria. That means the histology is high grade intraepithelial neoplasia or squamous cell carcinoma. The conclusion of this section, the careful endoscopic examination is the key for early esophageal cancer detection. The NBI can enhance the detection and access more easier. The endoscopic assessment is very important modality for evaluation of the depth of invasion and choose the proper treatment, including the endoscopic resection. Thank you very much.
Thank you very much, Dr. Prasit. We'll take questions at the end. Thanks. Thank you very much. It's my great honor and privilege to introduce our next speaker, Dr. Satoki. Dr. Satoki is the Deputy Director, Department of Gastrointestinal Oncology at Osaka International Cancer Institute. He is the board member of various gastroenterology societies across Japan, and he's going to talk to us about detection and characterization of early gastric cancer. This lecture is going to be an online lecture by Dr. Satoki.
It's a great honor for me to give presentation today. Thank you very much, Chairman, Professor Michael Lee, and Course Director Udomsawaengsup and Xavier and Hon-Chi and Olympus Corporations. This is my institute in Osaka, Japan. This is my COI. Today's my topic is about gastric cancer. Gastric cancer is the fifth most common cancer and fourth leading cause of cancer deaths worldwide. So this time, I'm talking about how to improve endoscopic detection of early-stage gastric cancer. The first point is identification of high-risk patients. Chronic infection of Helicobacter pylori causes sequential changes to gastric mucosa, including mucosal atrophy and intestinal metaplasia. On the background of such mucosal changes, atrophic gastritis, intestinal metaplasia, dysplasia, and finally carcinoma develop. So diagnosis of such mucosal changes help identifying patients at high risk to develop gastric cancer. Wemler reported that gastric cancer developed only in persons infected with H. pylori in New England Journal of Medicine in 2001. And in that report, intestinal metaplasia is shown to be a risk factor for the development of gastric cancer. And this is a cohort study by endoscopy we performed. And for histological evaluation of gastritis, we took biopsy from greater curvature of the antrum and corpus. And according to the distribution of intestinal metaplasia, patients were classified into three groups. I am group A, no intestinal metaplasia. I am group B, I am in the antrum only, and I am group C, I am in the corpus. And during the follow-up period of 6.7 years, 22 gastric cancers developed. 16 gastric cancers are from male and 6 gastric cancers are from female. This is Kaplan-Meier analysis of the proportion of gastric cancer development classified intestinal metaplasia distribution. I am group A, B, C. During the follow-up period, gastric cancer developed in 7 of 88 patients with I am group C, 8 of 145 with I am group B, and 7 of 497 in I am group A. Thus, male sex and intestinal metaplasia, especially in the gastric corpus, were risk for the development of gastric cancer. These days, Olga and Alzheimer's assessment are used for risk assessment of gastric cancer. These mucosal changes are usually diagnosed by histological examination of systematic biopsy specimens. Thus, taking biopsies are sometimes reluctant in aging society, and older patients sometimes took anticoagulant or antiplatelet like aspirin. Then, the Kyoto classification of gastritis was proposed at the 18th Congress of the Japan Gastroenterological Endoscopy Society for the purpose of standardizing endoscopic findings shown in the table. Among these, 5 findings with red letter were proposed for stratification of the risk of gastric cancer. atrophy, intestinal metaplasia, diffuse redness, enlarged folds, and nodularity. We perform cross-sectional study by endoscopy for evaluate these five findings. First endoscopic findings is atrophic gastritis. I will show representative images. Atrophy was evaluated according to Kimura Takemoto classification and classified as follows: none, mild, moderate, and severe. And endoscopic intestinal metaplasia represents grayish-white flat elevated region. Enlarged folds and tortuous gastric body folds not flattened on insulfation. And nodularity means nodular or granular elevated regions over the antrum and angle. At last, diffuse redness represents uniform redness involving the entire mucosa of the corpse. This is the result. In a univariate analysis, the severity of atrophy was associated with gastric cancer. 60 gastric cancer were detected in patients with 7 severe atrophy and 2 in those with no atrophy. Intestinal metaplasia and diffuse redness were also associated with gastric cancer. In a multivariate analysis, the severity of atrophy remained as risk factors for gastric cancer. So, the severity of endoscopic atrophy was found to be associated with gastric cancer. Thus, patients with severe atrophy should be examined carefully and followed up intensively. And there are other several observational studies which shows that patients with severe endoscopic atrophic mucosa have 3 to 4 times higher risk of gastric cancer compared to those who don't have endoscopic atrophic mucosa. Intestinal metaplasia is also seen in endoscopy, especially when we use narrowband imaging. Whitish color of the intestinal metaplasia is enhanced. And with close observation, we can appreciate rigid or villiform surface structure of the gastric intestinal metaplasia in NBI images. European doctors demonstrated that the quantitative assessment of these endoscopic findings in the mucosa correlated well with histological stage of intestinal metaplasia. Next, I will explain importance of optimal preparation. If the air is not insufficiently inflated, even advanced gastric cancer may be missed. The left image is less air, and the right image is with sufficient air. Moreover, if the mucosa or bubbles cover mucosal surface, we cannot evaluate detailed characteristics of the mucosa. Therefore, mucosal cleansing is always important for optimal lesion detection and characterization. Okay, next I will explain systematic observation of the gastric mucosa. Japanese Gastroenterological Cancer Screening Society recommend to take at least 20 photographs during upper GI endoscopy to avoid blind spots, but it's a little bit complicated and difficult to remember. Thus, Kenshi Yao arranged the photo documentation areas according to longitudinal and circumferential location of the stomach. Next, after optimal preparation and observation, it is important to understand characteristic findings of early-stage gastric cancers. Without knowing what findings to be picked up, the superficial regions cannot be recognized. One important idea is an that an early stage cancer doesn't look like a small advanced cancer. It is often represented as a subtle findings of mucosal height or discoloration. Basically, we try to recognize irregularity of the mucosal color and surface within a demarcated area. Irregularity means unevenness, asymmetricity, and heterogeneity of color and surface of the region, and application of the cross facilitates evaluation of such findings. So for polypoid or ulcerated regions. Benign regions basically show the same color and the shape in each quadrant, whereas malignant regions show different color and shape. For a superficial region, we also evaluate subtle findings of irregularity in color and surface in the demarcated area. And for superficial region, image-enhanced endoscopy such as chromendoscopy helps recognition of these endoscopic findings. So, how does image-enhanced endoscopy work for improvement of endoscopic detection of early-stage gastric cancer? There has been 3 randomized control trials to investigate usefulness for IEE on gastric cancer detection, and 2 of them showed positive effect of IEE on lesion detection. Although high-quality white light observation is still the standard method for gastric cancer detection, IEE could provide additional value. Thus, I personally screen with NBI after white light image for those with high risk, such as patients after ESD for gastric cancer. Lastly, let's focus on gastric cancer after H. pylori eradication. Recent RCT from Korea showed H. pylori eradication had reduced metachronous gastric cancer after endoscopic treatment of gastric cancer. Meta-analysis of RCT showed the efficacy of H. pylori eradication to reduce primary gastric cancer. However, gastric cancer still develops even after H. pylori eradication. Actually, in Japan, Japanese health insurance covered also H. pylori gastritis, covered H. pylori eradication also for H. pylori gastritis in 2013. However, gastric cancer does develop even after eradication. For detecting gastric cancer after eradication, we should know the characteristics of gastric cancer after eradication and who should be intensively screened. First, I will talk about characteristics of gastric cancer after eradication. These are characteristics of gastric cancer after eradication. Gastritis-like appearance is histologically epithelial with low-grade atypia, which means non-neoplastic epithelium. Other characteristics of gastric cancer after eradication is depressed type, small size, and intestinal type in histologies are reported. This is an image of gastritis-like appearance. Image A, the left one, is white light image by conventional endoscopy, shows slightly depressed region in posterior walls of the upper part of the corpse. A gastritis-like appearance under NBI under magnified endoscopy. And a gastritis-like appearance under NBI with magnified endoscopy was characterized by uniform papillae and or tubular pits with a whitish border, regular or faint microvessels, and unclear demarcation resembling adjacent non-cancerous mucosa. Histologically, well-differentiated tubular adenocarcinoma with low-grade atypia. The non-neoplastic epithelium partially covers the surface of the adenocarcinoma. This study gastritis-like appearance was initially reported by Kobayashi in 2013. The frequency of gastritis-like appearance was 44% in the eradicated group, which was significantly higher than that in the control group. Kitamura described an epithelium with low-grade atypia covering gastric cancer tissue after H. pylori eradication. They defined ELA, epithelium with low-grade atypia, as follows. The ELA lies on the surface of gastric cancer tissue. The ELA is columnar epithelium with spindle or oval nuclei. Nuclear polarity is present in the ELA. The ELA is separated and distinguished from the surrounding neoplastic mucosa. This is the image of gastric cancer detected 20 years after successful H. pylori eradication, captured using different imaging techniques. Magnifying blue laser image bright shows irregular surface pattern and irregular vessels. There are limited reports regarding detection of gastric cancer after eradication by image-enhanced endoscopy. Next, my topic is about who should be screened intensively. Risk factors of gastric cancer after H. pylori eradication are as follows: endoscopic atrophy, histologic intestinal metaplasia. These are same with gastric cancer with H. pylori infection. This study evaluated association between PPI and gastric cancer risk after successful H. pylori eradication in Hong Kong. The risk increased with duration of PPI use. Hazard ratio is 5 times, 6.7 times, and 8.3 times for 1 year, 2 years, and 3 years, respectively. This is a study from Korea and included more than 11,000 of patients. Also with H. pylori eradication patients, PPI use was risk for gastric cancer. Also from Taiwan, late eradication is reportedly associated with increased risk of gastric cancer. This is a movie of gastric cancer. Gastric subtle change, depressed region is at the angle of the stomach, and artificial intelligence on the left image can detect. Like this, also NBI image is okay. Today, I talked about these topics. I hope this presentation will help you detecting gastric cancer detection. Thank you very much for kind attention.
Thank you very much, Dr. Satoki. We will take questions at the end. I know you've got one more lecture after a couple of minutes, so I hope you can have a good break while we come back to you later. So thank you very much. We'll
Thank
come
you.
back to you later. Once again, I'd like to invite Associate Professor Prasit. He's going to talk to us about basic concepts of endoscopic resection of early UGI cancers. Dr. Prasit, please.
Thank you very much. The next topic is the basic concept of the endoscopic resection of early upper GI cancers. For this topic, I will talk about the early upper GI cancers, including the esophageal cancer, gastric cancers, and we will talk about the focus of the target lesion for endoscopic resection, the evolution of the endoscopic resection, endoscopic submucosal dissection and the indication for endoscopic resection. The target lesion for endoscopic resection, who's the patient candidate for the endoscopic resection. That means the lesion is a superficial upper GI neoplastic lesion without lymph node metastasis is the candidate for endoscopic resection. And the depth of the invasion of the cancers is very important. For the selection of the candidate for the endoscopic resection for upper GI cancers, we have to think about the factor of the histology, depth of the invasion, extent of the tumors, and define the risk of the lymph node metastasis. And the last one, we have to design for the treatment strategy that's suitable for the patient. For the evolution of the endoscopic resection in the blue colors, the endoscopic resection starting with the polypectomy. And the next era is in the green color, is the endoscopic mucosal resection. And nowadays we come to the era of the endoscopic submucosal dissection. After the polypectomy, come to the era of the endoscopic mucosal resection. The first technique we call the strip biopsy method using the single channel endoscopy. You see in the pictures, in the picture B, after injection, the submucosal solution to lifting the lesion at the mucosa from the muscular layer. The scope apply the snare and cut the lesion. But the problem is from the how to secure the margin of the lesion. The next technique, they use the double channel endoscopy by one channel, use the grasper to grasp the lesion, and another channel use the snare to cut the lesion. For the next technique, we call the endoscopic mucosal resection with cap-fitted pan-endoscopy, EMRC. This technique uses the transparent plastic cap that has the inside. We can apply the snare. After suction, in the picture B, we can cut the lesion. The next technique we call the endoscopic aspiration mucosectomy, EAM. This technique uses the accessory channel tube of hood that have the EAM hood and the crescent shape of the snare, and apply to suction the lesion inside and cut with the snare. And another technique to confirm the margin of the lesion, we call the EMRL, endoscopic mucosal resection using ligation. We apply the ligation to secure the margin before. After that, we use the endoscopy to snare and cut the lesion under the ligation. For therapeutic endoscopy, the first technique that we talk about is EMR. And the next technique, we will talk about the ESD, endoscopic submucosal dissection. The ESD has the advantage comparing to the EMR from the last lesion, because of if you use the EMR technique in the last lesion, they have the technical limit, and you have to cut with the piecemeal style that give the inadequate pathological result and increase the rate of the recurrence. For the endoscopic submucosal dissection, the step in the picture A to make the mucosal marking. That's very important because you have to clear the mucosa and define the border of the lesion. In the B pictures, we inject the submucosal solution to lifting the lesion. And in picture C, the step of the mucosal incision, and the step of the picture D is a submucosal dissection and complete en bloc dissection. The main idea of the endoscopic resection of superficial esophageal cancers that depend on the how to define the lymph node metastasis. And I talked in the section before for the depth of the lesion in M1 or M2. They have the 0% lymph node metastasis. That means the absolute indication for the esophageal cancer treatment with endoscopic resection is the define the lesion with IPCL B1. That means the lesion located in the M1 or M2. In Japan Esophageal Societies define now the indication of the esophageal ESD. We can apply the endoscopic resection to the T1A, that the tumor located on the M1 epithelial or M2 lamina propria. That is the absolute indication. And the endoscopic pictures, you have to see the B1 IP cell pattern or a vascular area small. And another one is a list of the strictures. Now, you can apply the endoscopic resection with non-circumferential or whole circumferential, but the length of the lesion has less than 5 centimeters. This is the sample of the cases. You see from the white line, the NBI and the magnifying endoscopy. You see the IP cell B1. After that, I apply the chromoendoscopy with Leukoid solution and make the mucosal marking. After mucosal marking, you have to check the margin again. And the next step is a submucosal injection to lifting the lesion from the muscular layer and make the mucosal incision. The mucosal marking is the guide for mucosal incision way. In this case, I use the glycerol plus indigocamin as the submucosal injection solution. After the mucosal incision, we do the submucosal injection again to confirm the lesion have lifting and dissection to the submucosa. After dissection, we complete the en bloc dissection. This is the case that I'm showing to you. On the left side is the white line and the NBI and the magnifying endoscopy with NBI demonstrate the IP cell pattern B1. The next is use the Leukoid solution to staining, and you see the Leukoid voiding area. And the next pictures, I perform the mucosal marking, submucosal dissection, en bloc dissection, and the last two pictures is the follow-up time after the ESD for 8 weeks. For the gastric cancers, the risk of the lymph node metastasis after you you assess from the endoscopy. The limitation of the lesion is on the SM1 because of the study showed 0% of the lymph node metastasis. In Kokotoda suggests the clinical pathological factors and the lymph node metastasis for early gastric cancers. You have to confirm about the depth of the invasion, that's a mucosa or submucosa. The lesion have ulcer or non-ulcer, the size of the lesion and the differentiation. You see the absolute indication is the lesion that located at the mucosa, no ulcers, and the size less than 2 centimeters, and have the pathologies defined as a differentiate type. You see in the blue colors, and the extended indication is on the yellow colors. That means if you see the lesion less than more than 2 centimeters, you need the mucosa in the depth of the lesion, no ulcers, and pathology is differentiate type. But if you see the pathology is undifferentiated type, the lesion has less than 2 centimeters, is the candidate for the extended criteria. For the ulcer lesion, the located of the depth must be inside the mucosa, and the lesion has to less than 3 centimeters. And if the lesion deepers to the SM1, that means the lesion have the differentiate type less than 3 centimeters. This is the candidate for the extended criteria of the endoscopic resection. This is the sample case of the gastric ESD. After the defined from the white light NBI and chromoendoscopy with the indigo camine, we make the mucosal marking. After mucosal marking, I perform the submucosal injection and mucosal incision. The dot is the guide for us to make the mucosal incision when we close to the lesion. This step is the submucosal injection again to lifting the lesion and perform the submucosal dissection. You can use the knife for dissection, and if you see the small vessel, you can use the knife for the stop the bleeding that we call the pre-coagulation technique. After coagulation, you can cut. And for the last of the vessel, we can use the coag grasper to make the pre-coagulation technique before and cut the vessel and dissection. Finally is a complete en bloc dissection and remove the tumors. This is the case in the sample case of the gastric ESD. In the picture A is a white line, and the next is the NBI. And picture C, you see the magnifying endoscopy that have the demarcation borders with abnormal vessel and abnormal surface. The next in the picture, this is a chromoendoscopy, and we perform the mucosal marking, submucosal dissection, and the en bloc dissection. For the conclusion of the basic technique of the ESD, the understanding of the endoscopic concept and technique is very important. The early detection of the esophageal and gastric cancers is very important to increase the chance of the successful treatment and have the good survival outcome for the patient. The superficial upper GI cancers lesion that candidate for the endoscopic resection must have the no risk of the lymph node metastasis. The EMR has the apply for the lesion, but if you see or candidate the lesion is the last lesion, the ESD has more advantage because you can cut the more larger of the lesion and you can have the adequate pathological result and decrease the recurrence rate. The ESD is the feasible and safe minimally invasive technique that can preserve the upper GI function and have the precise histological evaluation. Thank you very much.
Thank you very much, Dr. Prasit. We'll now move on to the last lecture of this session, which is by Dr. Satoki, who will talk to us about technical considerations of ESD.
Okay, I will start. Thank you very much for giving me this opportunity again. This time, I will talk about technical considerations of ESD. This is my COI. And I think to complete ESD, these are important steps: anesthesia, scope selection, marking, injection, incision, and mucosal incision, and submucosal dissection. First, there are several types of anesthesia: intravenous anesthesia or general anesthesia. In Japan, general anesthesia is a little limited. So intravenous anesthesia is mainly used for ESD. Petizine and midazolam is a standard anesthesia, and if we need more stronger anesthesia, dextromethorphan or propofol can be a candidate. And as for scope selection, usually magnified endoscopy for marking, and ESD with endoscopy with water jet function is used. However, in special situations, other types of scopes is used for pharynx region. Multi-bending scope is very useful to access to the region. And there's in a certain location like pylorus and cervical esophagus, wide down angle scope is necessary. So sometimes we use even colonoscopy, which has wide down angle of 180 degrees. And in stenosis can be usually managed by balloon dilation. However, if we cannot, or in a complex location, ultra thin endoscope is useful. I will show the movie later. Marking is, I think, most important part in ESD because precise diagnosis of extent of lesion is crucial for curability. Usually, we perform marking with weak magnification or even without magnification. If it's difficult to identify demarcation line, of course, we can use full magnification. For upper GI ESD, also for lower GI ESD, traction-assisted ESD is common and very useful. This is a typical movie of esophageal ESD with traction-assisted method. The region is located at the anterior left part side, and this is after using iodine. We can add marking we make marking with NBI, and then we confirm by using chroma endoscopy. This is a movie of injection, and then we'll perform causal incision like this. And then submucosal dissection. Next, clip with lines applied to the oral side of the specimen. By applying line, tension, making a tension is become easy, and it facilitates easy dissection. We performed a RCT randomized control trial if the traction-assisted ESD is useful for esophageal ESD or not. Patients were randomized to conventional ESD or traction-assisted ESD. Inclusion criteria was lesions equal or larger than 20 millimeter, and clinical diagnosis of invasion depth was T1A or SM1, slightly invasive submucosal cancer. In this study, lesion located near the previously endoscopic resection scar or history of radiation or surgery and stenosis were excluded. And the procedure become difficult. We can change from the conventional ESD method to traction-assisted method. Primary endpoint was ESD procedure time. And sample size was estimated as 210. And this is the result. 241 patients were enrolled to this study, and 120 were assigned to conventional ESD without clip with line, and 121 was assigned to traction-assisted ESD. This is the patient's characteristics. Median tumor diameter was 30 millimeter, and most of the region were located at middle thoracic esophagus. This is the results. Procedure time was significantly shorter in the traction-assisted ESD group, 45 minutes, compared with conventional ESD group without traction, 60.5 minutes. Thus, traction-assisted ESD was superior to conventional ESD in terms of procedure duration and was not associated with any adverse events in esophageal ESD. And this is the ESD movie of the gastric ESD. The region is located at fornix, and firstly, we made markings using NBI, like this. This movie is published at eVideo in 2020, and after make mucosal incision, we perform causal incision using food, transparent food. By attaching the transparent food to the gastric mucosa, scope becomes stabilized, and we make submucosal dissection using IT knife, and then clip with line was applied to facilitate submucosal dissection, like this. By pulling the clip slightly, submucosal layer become clear. Good visibility was obtained, and submucosal dissections become easy. And the second clip was applied to easy dissection of the posterior wall side. Huge lesion in the fornix, and also third clip was also applied. further dissection was proceeded like this. Fornix is very thin compared with antrum. So some perforations occurred and clipping was done. And block resection was obtained, and the histological diagnosis was mucosal adenocarcinoma without lymphovascular invasion. Next, I will show a movie of controlled bleeding. This is the lesion as the body, and submucosal dissection was performed using IT knife. Like this. And water jet function, by water jet function, we make slight submucosal excision by saline. Then I dissect from right to left and bleeding occurred. However, IT knife has strong power of controlled bleeding and can stop just with knife, like moderate bleeding like this. Okay. Next slide shows the usefulness of RDI, which Dr. Hon-Chi explained. When bleeding occurs, it is sometimes difficult to identify the bleeding point. And it was a little difficult to stop bleeding. Then I switched to RDI mode, and the bleeding point became clear. And using coagulation forceps, I can stop bleeding easily. Next, the region located at cervical esophagus is sometimes difficult. I will show the movie. ESD for cervical squamous esophagus, cervical esophagus extending to esophageal entrance is technically challenging because of tightening of the upper sphincter muscle, narrow working space, and pharyngeal reflex. This general anesthesia makes the sphincter muscle relaxed and aids maneuverability of the endoscope. In addition, laryngeal elevation using laryngoscopy provides a wider walking space. In this patient, endoscopic examination using pyridine hydrate was difficult to capture the entire lesion due to the sphincter contraction and the pharyngeal reflex. But general anesthesia with endotracheal intubation and laryngeal elevation enables us for capture entire image. And also procedure of the oral side become easy like this. This is a part of the cutting oral side, which is located at this is ectopic gastric mucosa. These are about esophageal entrance. So we perform mucosal incision from the oral side. Usually, I perform mucosal incision from the anal side, but if we proceed from the anal side, the lesion switch to oral side, and the dissection would become more difficult. So I started from the oral side. And now circumferential incision was completed. And again, clip with line was used. And submucosal layer was easy to identify. And if submucosal layer slightly away from the muscular layer and specimen, it's easy to dissect. And en bloc resection was obtained. We injected Kedacol steroid for preventing stenosis after ESD because the mucosal defect exceeds half circumferential. And also the cervical esophagus is a risk factor for stenosis after esophageal ESD. Next, I'll show you the usefulness of ultra-thin endoscope. A case is a 62-year-old woman underwent subtotal esophagectomy for esophageal cancer, local resection of pharyngeal cancer with post-operative radiotherapy, and bilateral cervical lymph node dissection due to pharyngeal cancer metastasis. Pharyngeal cancer was controlled, but follow-up endoscopy revealed a 10 mm brownish area in the cervical esophagus consisting of type B1 vessel, and the biopsy revealed neoplasia. This is a video. ESD was performed under general anesthesia because the lesion was located in the cervical esophagus. We started marking with a magnified endoscope, H290Z Olympus. However, we couldn't mark the depressed area. Thus, we switched to colonoscope with a wide down angle and complete circumferential marking. Next, we performed mucosal incision, followed by submucosal dissection using a clip with line. Like this. However, we couldn't dissect the posterior and left side because of the restricted maneuverability of the scope due to previous surgery and radiotherapy. Then we switched to ultra-thin endoscope, GIF, XP219N, which with a newly developed knife, Endosaver Fine, which can be used with ultra-thin endoscope. This is a new knife. And proceeded submucosal dissection. This is a specimen. A pathological diagnosis was squamous cell carcinoma without lymphovascular invasion with negative vertical margins and indeterminate horizontal margins. Follow-up endoscopy 1 year after ESD revealed no local recurrence. Lastly, I will show management of perforation. Perforation during operation, during ESD, can be usually managed by just simple clipping. And also delayed perforation can be almost of delayed perforation also can be managed by endoscopy. This is a video recently published in a video. We closed a large defect using Groups line method. Perforation during ESD can lead to severe complication, localized. This is a lesion at 12 mm squamous cell carcinoma visualized in the middle esophagus. Circumferential incision was made using flash knife, and Groups line was facilitated as usual. Our young colleague performed this procedure. A large perforation occurred during submucosal dissection, suggesting the presence of unexpected mucosal defect immediately deep to the lesion. Like this. ESD was completed and the lesion was resected en bloc. Then we have to close that large defect. So we use the reopenable clip over the line method. Clip with line was applied like this, and second clip was applied, and line was tied. And subsequently, third clip, fourth clip was applied, and entire defect was closed like this. And curative resection was obtained. And this is a picture of just two weeks ago. Many foreign doctors come to our department. Now 8 foreign doctors we are accepting many foreign doctors. Thank you very much for kind attention.
Thank you very much, Dr. Satoki. As impressive as your mentor, Professor Uedo, you exhibit excellence in your skills and certainly patience. I think all those flipping, opening and closing of the esophagus that I see, I'll probably faint by the time I finish my ESD, but you're truly patient and I admire you for that. Please stay online with us. We've got a 15 minutes Q&A answer after a few lectures. So any questions from the audience? Okay, I'll start off while the rest think. And this is equally to Hon-Chi, to Prasit, and to yourself. So the field of endoscopy, diagnostic endoscopy, has advanced tremendously. From simple white light to NBI to dye-based to magnification. And we heard from Dr. Satoki about how to do a good endoscopy and do it well. So how do you put this together for a trainee who's coming into either gastroenterology or surgery to deliver the best care to the patient? You know, you can use iodine, you can use NBI, that is time consuming, it requires training, you can look at loop patterns in vessels, you can look at abnormal mucosa, but there's a lot of surface area to cover. So what would each of my honorable colleagues think to advise Is there an algorithm you use, or do you go to find something abnormal and then work on it? What are your advice, if I may get all three of you to comment? Can I start with you, Hon-Chi, since you started with the...
Yes. So, can you hear me? So, I think you have asked a very, very relevant question. So, we show fancy stuff. We show magnified endoscopy. It seems will take a long time, but at the end of the day, we are hoping to help our patients through endoscopy, through training. So, how do we achieve that? In my opinion, the first thing we learn as an endoscopy is not fancy stuff. We always go back to basics. So how do we appropriately detect cancers? At the end of the day, if you cannot see cancers, there's no point doing all this fancy magnifying endoscopy. So I believe we've heard a lot from Satoki and Dr. Prasit as well. So in the upper GI field, for example, it all comes back to preparation. How do you prepare the stomach? How do you prepare the esophagus? How to clean all the mucosa? These are not stuff that needs someone who is very, very experienced. These are actually just practical tips. How to distend properly the stomach so that you do not miss blind spots. So have a systematical way to assess the stomach so that you don't miss somewhere. So for that, maybe Professor Yao's SSS, systematic assessment, will be very helpful. IEE do comes into place. For example, for esophagus, just a simple click of the button, press of the button to an MBI would definitely help you to find out potential neoplastic lesions. You do not need to change immediately to magnifying endoscopy. At least you can find it and maybe get a biopsy and then refer to somebody who has the experience for advanced diagnostic skills. So these are things that I think important for us, also for people who are just starting to learn endoscopy, so that you're at least able to find out the abnormality. And then you can proceed to maybe learning how to characterize it if you have enough experience. So that's my own.
Thank you, Dr. Prasit.
Okay, I agree with Dr. Yip. Like for detection of the early cancers, the mucosal watching and preparation for the endoscopic examination is very important. You can use like from the white light to detect the abnormality of the surface if you can clean the surface. After you have to detect the difference of the colors or structures or the area, you can use the basically of the Bowman or the Paris classification to define this is the superficial cancers, and use the other modalities like the NBI, magnifying endoscopy or chromoendoscopy, that have the different technique that's suitable for each organ, such as the esophagus or the stomach. And the last one, I think experience is very important. If you have the time, you have to attend to many of the master in Japan, in Thailand, in Hong Kong, in Singapore, and you see many of the cases. This is very important to detect the early cancer to help the patient.
Thank you, Dr. Prasit. So apprenticeship still remains a key observation, being a key learner just by looking at people doing things is exactly what we've heard now. Dr. Satoki, what are your thoughts?
Thank you very much. I totally agree with them. And preparation is also important. And anesthesia, selection of anesthesia is also important for just examination. And among them, white light observation is the basic and most important. And we check and pick up, detect lesions. And NBI, as for NBI, for esophageal observation and pharyngeal observation, NBI is very useful. So I go through white light with the white lights and go back with NBI for esophageal observation. And chromoendoscopy is also useful for esophageal lesion detection. So for high-risk patients such as endoscopic resection after esophageal cancer or pharyngeal cancer, chromoendoscopy for esophagus is recommended. And magnified endoscopy is a cross examination, so it's we use after lesion detection. And as Hon-Chi said, systematic observation is very important to prevent blind spots. And if you detect some suspicious lesion, you should observe closely after systematic examination. That's my opinion.
Thank you very much. Any questions from the floor?
Maybe can I add one more comment about this? So the other thing I think is important that has been covered both by Satoki and Prasit is risk prediction or risk assessment. Because when you do an endoscope, you know the patients beforehand. For example, if a patient is a heavy smoker, heavy drinker, or Chinese, or they are flusher, Asian flush, then you know in mind, okay, this patient might be of high risk of esophageal cancer. Or if a patient is a known HP infection, or when you go into the stomach, you see, oh, there's so much of atrophy in the stomach. So these are patients you might want to focus a little bit more time, spend more time to clean and see if you might detect some early cancers. So I think risk assessment is also something to keep in mind always.
Thanks, Hon-Chi. Kanoka, you had a question, a comment?
Because mostly endoscopists just started to diagnose the early gastric cancer, right? And they have such less experience to see and diagnosis. Mostly they're trying to do the biopsy to confirm that is the cancer or is not cancer. So what is your suggestion for them? Should they do the biopsy or shouldn't do the biopsy? And another one is if we do the biopsy, is interfere the ESD or the EMR in the later for the treatment of the patient? What is your suggestion for them?
Well, maybe I'll try and answer. So very, very relevant question. But indeed, for myself, when I was learning a few years back, I actually took a lot of biopsies because I was uncertain. I was still learning. So I don't think there's a problem with getting more biopsy if your institution allows the cost for it. But in my opinion, I was actually very interested in what I found and what I could correlate with my biopsy results. So I would encourage those who are learning to get more biopsies. If you're uncertain, just get a biopsy, and through that you can actually learn. So of course, go back and trace the biopsy yourself so that you can learn from your own experience. And I don't think it will affect any of the ESD procedures. So maybe Satoki or Prasit can comment on a bit about how a biopsy may affect ESD difficulties.
Okay, I totally agree. This is Satoki. I totally agree with Hon-Chi. Taking biopsy is necessary if you are uncertain. And the frequency of biopsy will decrease during your become experienced and skilled. And as for effect of biopsy to ESD, there is little effect on gastric ESD or esophageal ESD. And also for flat region of the colon or duodenal region, biopsy sometimes makes ESD difficult. However, for duodenal small regions, usually we perform underwater EMR, and biopsy is no problem for underwater EMR. And for chronic flat region, biopsy is not recommended. And for chronic flat region, diagnosis of tumor is relatively easy. Of course, it's difficult to distinguish definitely between adenoma and adenocarcinoma. However, diagnosis of tumor, which is indicated for resection, is relatively easy. So the biopsy is not recommended for colon, but for esophageal or gastric ESD, it's no problem. And sometimes diagnosis of gastric regions are difficult. So taking biopsy is desirable, I think. And even if biopsy was taken, pathological diagnosis by just biopsy is sometimes difficult. So if you endoscopists suspect that this is tumor or gastric cancer, you should follow up closely, even if pathologists say it's benign. That's my opinion.
Thank you very much. Any more questions? I have one, Hon-Chi, for you and for Prasit and for... As we move into the next era of development of endoscopy, AI comes into play a big role. Would you vision ultimately that AI will perform the initial screening and giving you that, you talked about systematic looking at the stomach, and AI will help you do that, and then endoscopists will remain to do targeted screening of those areas? Is that the new development? What are your thoughts about AI?
Okay, so I'll begin. I think so. There are two things here. So first is, how is AI going to help our regular endoscopy, and maybe second thing is robotic going to be involved for automation, because that's the other thing that might come if AI has been so developed, and we might have automated movements that will help to guide us through the assessment. So I think for automation maybe a little bit far-fetched, but AI is definitely coming in our daily practice. So I think Satoki mentioned a little bit about that. For upper GI, I think it's less developed than the colorectal counterparts. So you know that nowadays there are so many different systems that will help you to detect or characterize colonic polyps. Upper GI seems to be less developed. I think maybe because gastric cancer is still a very hard to detect disease, even if with the AI. I think there are some companies who are coming up, for example, AI Medical, who has a device that has been recently developed and somehow validated, but still not yet very widely adopted. Esophageal, similarly, there are some aspects that's coming, but I think at the end of the day, what most studies are showing is that AI can perhaps perform similarly with experts, but slightly better than trainees. So, and the other thing is, ultimately, if you cannot prepare the situation well for the AI to interpret, the AI still cannot see the cancer. So it still comes down to basic techniques of an endoscopist. And then maybe the AI will help assist, but still we still have to have our own interpretation. I was told that recently there's a litigation in the United States that a doctor was sued because he trusted a wrong AI diagnosis. So that might happen in the future, which we don't know what will happen, what will end up be. But at the end, we have to have our own doctor's instinct. At the end, I think.
Thanks, Prasit.
I think the AI can help me in the futures for detection, but back to the basic, like the endoscopists have to cleaning the mucosa and move the scope into the area that you suspected, which area is the cancer, and the AI can guide you or help you for the more information. And I think the basically of the endoscopic examination to make the systematic examination is very important to confirm that you did not miss the area of the cancer, like the professor that talking before, in the stomach you have to full inflation to confirm that you did not have the lesion. And after you examine the endoscopy, the AI can help you.
Thank you. Dr. Satoki, do you have any differential opinions?
Yeah, almost same. I also have some experience of AI research about endoscopy, and already some RCTs are published about colorectal polyp detection. But however, for upper GI, AI is somewhat difficult because of the wide variety of disease regions, morphologies for upper GI. And as Hon-Chi and says AI can only recognize and detect which on the image. So endoscopists have to maneuver. And also, the other point is AI only can detect what AI learned. So we have to teach AI. And so AI is suitable for diagnosing, detecting colorectal polyps, but the very rare disease is also difficult to diagnose. Thank you.
Thank you very much. Yeah, so I think for the trainees in the room and who are online and listening to this, so it's always back to basics, and there is no alternative to good basics. All right, so if you can't handle, navigate the scope, ESD, EMRs, therapeutic interventions, and advanced diagnosis are far from your reach. So I think the basic tool that we all need to learn are, again, the key, and that is where the foundation is the most important thing. I think that's a great message to take back from all that we've started with basic and ending it in a very advanced note. I thank all the speakers who have been part of this session for wonderful talks, something that I learned myself a lot. So thank you very much. I will bring this session to a close. I would request all the participants and faculty to stay. We will have a picture right in front here. So thank you very much, and we'll have a tea break after this.
Assist Professor Kanokkan Thepmalai for be a moderator for next session. She is an Assistant Professor, Pediatric and Bariatric Surgeon, Faculty of Medicine, Chiang Mai University. Please welcome.
Thank you very much, and welcome back again to the 8th APELS for the upper GI cancer. And the first topic in the second session is going to be provided by Assistant Professor Hon-Chi from Hong Kong. He is the clinical assistant and professor, and he is very keen for the endoscopic and laparoscopic. So please.
Thank you, Kano-kan, for the kind introduction again. So my topic today, the next topic will be on laparoendoscopic surgical approach, which is probably the key area of our APELS teaching. So what we want to combine endoscopic and laparoscopic surgery. So if we look into the history of surgery or a history of endoscopy, you will see quite interesting trends. So at first, of course, we are in the beginning era of surgery, we want it to be safe because at that time there were no technology to help us. We just want the patient to survive. With time goes by, we want to be helping patients who have cancers to really survive from the cancers. So we move on from safe surgery to oncological surgery, where we want to resect as much as possible. We're doing extensive lymph node dissection, but at the expense of patients' functional outcome. So in recent years, surgery move on. So we are hoping to maintain our oncological outcome, but yet we hope to preserve patients' function. And that's when we have organ preservation, we have minimally invasive or minimal access surgery, trying to maximize our patients' functional outcome after surgery. So on the other hand, diagnostic endoscopy probably was what it could be done in the beginning. There's no fancy instruments, no ESD knives, nothing. So we could only do diagnostic endoscopy at first, and then people start to do more complex procedure like therapeutic resection, polypectomies, EMR, and eventually into ESD. And in recent years, of course, we all know that with the advance in our techniques and experience, we are able to go beyond just inside the lumen. We are able to go into the submucosa and form a so-called third space endoscopy, and even going outside into a full thickness resection. And actually, this two can be combined. So in this lecture, I'm going to show how endoscopy and surgery can harmonize each other. So if we talk about GIST, for example, so it's quite traditional that GIST, the principle of management of GIST is usually with resection of the entire tumor with a negative margin without the need for lymph node dissection. And if you look into recent guidelines, laparoscopic surgery is definitely one of the good approach for smaller, lower risk lesions that you can completely resect with safety and also prevent spillage or tumor capsule perforation. So maybe most of these lesions will be managed by wet resection, just aiming to achieve a margin negative resection, preserve of as much stomach as possible and avoid major gastrectomy. But it's not without problem, because wet resection is difficult in some target location, like if you're doing it in the cardia, in the antrum, you might end up with stenosis, or you might even staple up the esophagus and end up with a disaster. And sometimes it's even difficult to see the tumor because the tumor grows inside the lumen, and from the outside, you hardly see any of the tumor. And maybe sometimes in certain situation or tumor morphology, you have to resect a huge amount of normal stomach in order to achieve resection of maybe not a very sizable tumor in certain location, and you end up with poorer functional outcomes. And so this is why a combined approach, we call it LEX, or laparoscopic endoscopic cooperation surgery, was being explored. So maybe the first inventor of this procedure is from Japan, Professor Hickey. So he proposed this technique. So I'll show just in this video. So this lesion is in the cardia, just 1 cm distal to the EG junction. So you can't do a wet resection with this kind of lesion. You may consider alternative approach by doing just a proximal gastrectomy, but also that will end up with some poor function outcome. So we chose to perform this combined LEX procedure, a classical LEX procedure. So we begin by mobilizing the lesser curve, so as we able to see exactly where the tumor is from the outside, and also with the guidance of the endoscope. So you can see this tumor on the endoscope in the lesser curvature cardia side, quite a sizable tumor. So this kind of tumor will be difficult to be just resected purely by endoscopy. It was like 5 or 6 centimeters. So what we did is a combined resection. So with the ESD technique, we dissect the endoscopically. So to perform a mucosal incision from the inside, and also dissection of the tumor around the normal mucosa. So of course you don't need to resect a lot of mucosa in this situation, because most of the time the tumor is located in the muscle layer. So you can preserve certain amount of normal mucosa. And after a circumferential mucosa incision with the various advanced endoscopic knives, then you'll be able to see exactly where the tumor is located, as you can see here. So these are also normal submucosal tissue. You can see the blue color very nicely. And then you see the tumor capsule on the left side of the scope view. So now we always keep as far away from the tumor. We shouldn't rupture the tumor capsule, because this is the basic principle of GIST surgery. And so once you get an adequate circumferential mucosal incision, then you can start to cut onto the muscle layer. So in a minute, you see this is the muscle layer beneath, and the tumor is on top. Okay, so then you will try and mobilize further, and then start to cut the muscle layer. So let me see if I can fast forward. Okay, so now cut outside with the endoscope. And this is also when we will see it from the outside. See the gauze there? So this is actually combining at the same time we're seeing it from the laparoscope. So in a minute, you will see how it looks like on the endoscopic, on the laparoscopic view. So the video is not streaming that smoothly. So from the outside, you now see my scope and my device coming out. So you don't need to open circumferentially with the endoscope, because once you open a small opening in the muscle layer via the endoscope, the subsequent resection can be done easily with the laparoscopic device. So now you see how the perforation is being made artificially, and then I just dissect the residual layer with advanced energy device, and then I can resect this lesion completely without involving the margins, and also preserving a majority of the normal mucosal, normal wall of the stomach. So at the end, all I needed to do after resecting the tumor is just to suture close this defect, which is quite easy if you have enough laparoscopic experience. So this is the basic of legs. So there are many reports of classical legs. Generally speaking, the outcome is extremely good without much complications, and most of the patients has excellent functional outcomes without any motility disorder or abnormalities. But the only problem with the classical legs is potential contamination, because you will have some inadvertent spillage of the gastric juice or tumor cells and theoretical risk of tumor seeding. So there has been some modification of the techniques trying to not to expose the luminal side into the peritoneal cavity. One of which is called inverted legs, where stay stitch is being placed on each end of the edge of the tumor, so that the tumor will invert inside into the lumen to reduce the contamination. But otherwise, the concept is quite similar to the classical legs. Another procedure is called CleanNet. It's developed again by Professor Inoue. So this time, we're actually creating a serosal incision instead of a mucosal incision. But we still need to inject and elevate the submucosal layer first. And then afterwards, we will pull the lesion outside of the wall of the stomach and then staple it off, and then just suture the serosal defect afterwards. So it's better to be illustrated by a video. So you can see this tumor is located in the posterior wall of the antrum, and the part of the lesion is extraluminal and part of it is intraluminal. And at that time, we thought that performing just a wedge may end up with maybe an angulation or a rotational problem in the angular incisura. So we decided to perform a combined laparoendoscopic procedure. So at this point, we still need to dissect the extrinsic momentum and all the lesser curvature vessels to avoid bleeding afterwards. And then we would proceed to, so after freeing up all the mucosal, serosal attachment or vascular attachment to the stomach wall, then we proceed to endoscopic view. So now you can see that the tumor around has been isolated. If you just staple it off, you might end up with a quite significant stenosis in the angular incisura. So that's why we changed to the approach, and we changed to endoscopic injection. You don't need to resect anything endoscopically. All you need is just to inject around the tumor, almost like an ESD injection. But then now, as opposed to a ESD with mucosal incision, you're doing a laparoscopic serosal incision and dissect it open. So this is the view after injection around the tumor. And then you can also see it externally with the bluish color. And you can just incise it with a hook or with laparoscopic instruments. And then eventually you see all these submucosal elevation being created by the injection, almost like you're doing a reverse ESD, but you're keeping the mucosa intact without perforating into the lumen. And you will also be able to see the tumor capsule at the same time. And by gradually performing a circumferential serosal incision, then you can actually pull the entire lesion out into the external part, into the serosal side. And you can see this is the mucosa. The whitish is the mucosa. So this is an adequate circumferential serosal incision. And then you just staple this off and then repair the seromuscular defect. So see now I'm stapling off the mucosal defect and checking it inside with the endoscope. making sure I didn't really cause any major structural abnormalities of the stomach. And after stapling, it's quite easy. All we need to do is just suture back up the serosal side. So a lot of work with upper GI surgery is with suturing. So maybe tomorrow we'll talk more about how to properly perform laparoscopic suturing, but it's also an integral skills as an upper GI surgeon to perform good suturing skills. So at the end, we will close this serosal defect and the functional, basically the stomach has minimal distortion afterwards. You can see this on the endoscopic view. Basically, there's no, it's almost like an intact stomach without much change in the contour. So the other option is non-exposed inversion surgery. So this is similar to CleanNet, but the only difference is that now instead of doing a serosal incision, you're also doing a serosal incision, but then afterwards you're actually inverting the lesion into the intraluminal side and then dissect it from the inside to complete the dissection and retrieve the entire specimen from the oral cavity. So I believe this procedure may be less useful for GIST, because if you are able to invert it, you can just do an endoscopic full thickness resection. But anyway, this is one of the cases that we did with the NEWS device, NEWS procedure. So again, similarly, serosal dissection to make sure that we have adequately dissect around the vessels, and then injection to elevate the submucosal layer so that we create a good cushion around the lesion. And then we move on to a serosal incision afterwards around the marking that we already did. And this part is similar to what we do for the CleanNet. So basically just dissect it around the tumor and see all the submucosal injection solution. And then afterwards, we will push this whole lesion inside the lumen with a spacer. So the spacer helps us to separate the serosal closure with the lesion itself. So you see it in a minute, how we invert the lesion. So we push this whole thing inside, and then we add a piece of gauze into the serosal side. Okay, and then we just suture this. So after suturing this completely, okay, you can see that now the serosa has been completely closed. Then we start from internal. So we go back to the endoscopic view, and then now basically what's left is the mucosa. So all we need to do is to perform a mucosal incision, and basically then the tumor will be completely, can be completely retrieved. And the spacer, this black gauze, is there to avoid us to cut incidentally deep into the serosal closure side. So it will help us to make sure that the plane is the correct plane. And so this is how it looks like after a complete resection. And of course, with this, we will also hope to close the mucosal defect, simple by usual clips. Because the serosa has been closed, so this mucosa will be approximated quite nicely. So this is how it looks like afterwards. So mucosal with clips, externally with sutures. So this is a CleanNet procedure, and also similarly, studies have shown, or basically case series have shown that this is a very good device, technique for these kind of lesions that are majority intraluminal. So another technique is called closed legs, quite similar to the NEWS that I mentioned. Again, in serosal incision, inverting it into the lumen, and then taking it out through the oral cavity. And so this is similar, and studies have also shown that this is a reasonable technique, but the only problem of this is because there is a slightly higher incidence of mucosal injury. So because they did not perform a mucosal incision first in this procedure, so they only mark it. So after inversion, it may be there may be a higher risk of perforation with the endoscope. And so just a short summary about the comparison of different legs. So most of these are suitable for lesions that are less than 5 cm, or if you need to take it out through the mouth, it's lesion less than 3 centimeters. And they are suitable for most of the location, and but it will take a little bit longer time than a wedge resection. And there are various ways of closing it with hand suturing or stapling. So you can also do it with ICG. So this is one of the example when we actually utilize ICG to help us to find where the tumor is. And this might be helpful in situation when the tumor is completely intraluminal. So you can see that we mark the lesion by injecting around it with a mixture of saline and ICG. So the tumor now comes very nicely so that we can perform this serosal incision even more precisely than the previous techniques with just injection with maybe indigo carmine. So because of time, I would not go on with this video, but I can show you that the outcome was also very good with this ICG technique. So we also try and do the similar procedure even in esophageal tumors. So in large tumors, then we can also do it. An example of a video, oops, sorry. So maybe I'll show briefly this video. So this patient has a 5 centimeters esophageal schwannoma. Again, it's impossible to resect endoscopically because of the size. But if I do an esophagectomy, it will also be quite an overkill for the patient. So what we did is almost like a clean net, but in the thoracic part. So we inject again, trying to elevate the lesion away from the underlying mucosa. And then we change to a VATS view. So this is the VATS view showing the right lung. We access through the right pleural cavity. So you can see the whitish tumor over here. So of course, we need to dissect it away from the lungs. So you can imagine this cannot be done with a pure endoscopic technique. Otherwise, we have to resect part of the lungs. And then we mobilize around the lesion until we see the esophageal wall. So you can see now we are dissecting the pleura around the tumor, and then until the point that we see the attachment to the esophageal lumen or esophageal wall. So you can see this is behind this is the esophagus, and the tumor is now being dissected from the bluish injected mucosa, so as to preserve as much mucosa and the esophageal wall as possible. And basically, we were able to enucleate the entire lesion with just a hook diaphragm and with some advanced energy help to dissect the surrounding vascular attachments. And so that leaves us with only a adventitial muscular defect of the esophagus. And because we have preserved as much as normal surrounding mucosa as possible, so closing it, this defect would luckily did not end up with any stenosis of the esophagus, because the most worrisome part of this procedure is whether we would have risk of stenosis of the esophagus. But so this is a very nice mucosal, healthy mucosa left behind, and then we just need to suture it close afterwards. So I will not show the entire video because of time. But at the end, so this is how it looks like afterwards, with a very good intact esophagus, so organ preservation. So in conclusion, I think the principle of GIST resection should always be followed with a margin negative en bloc resection without tumor rupture. But we are now seeing an increased ability of our resection techniques with the addition of endoscopy during surgery even for larger tumors in order to achieve maximum organ preservation and functional preservation. So thank you very much for your kind attention.
Thank you very much, Dr. Hon-Chi. So we will move to another speakers because we have the Q&A session in the last. So the next speaker would be Dr. Associate Professor Jirawat Swangsri. He is the upper GI surgeon from Jirawat Hospital. He will be present about endoscopic palliation for tumor obstruction, please.
Thank you very much, Dr. Kanokkan and Professor Michael Lee, Professor Suthep, Professor Asim. Thank you very much for APEL. This is my first time for APEL, and a very great honor to be here. Okay, I will talk about the palliative of the esophageal stent today. I think the esophageal cancer and also benign esophageal condition is also a big problem for many areas in the world, so also in Thailand. The esophageal cancer is a big problem because we have a new case, around 2,000 cases per year, and in US we have they have around 14,000 cases per year, and most cases of unresectable. In Jirawat Hospital, the case of the esophageal stent is around for 5 years we have around 51 cases, and we have 63% is malignancy. So the evolution of the stent is they have created in the world so many like evolution of the stent have from the first generation is a bimetallic, so expandable metallic stent, and the second generation is a cover cell expandable metallic stent, and third generation is a retrievable or fully covered cell expandable stent, and fourth generation is a anti-reflux stent. Fifth generation is a radiation emitting cell expandable metallic stent, and the latest one is a biodegradable. But however, the fifth and sixth generation is not so available, and the benefit is still curious until nowadays. So the common use in the Jirawat Hospital is also the common use in Thailand and Jirawat Hospital, also the second, third, and fourth generation. The material that common use also in USA and in Europe is stainless steel and nitinol, and polyurethane and the PTFE anti-reflux is quite less common. The diameter, common diameter is around 18 to 22 or 23, depends on the brand of the manufacturer, and the length is around 6 to 15 millimeter. Centimeter. And introducer, when it before to deploy, is around 5.8 to 14 millimeter. The property of the stent, you have to define the ideal of the property, like the optimal radial force to maintain the stent patency, and the minimal of the irritation to reduce the overgrowth of the granulation at the proximal and at the end of the stent, and then for shortening after stent deployed, the length of the stent should be stable, and the minimal of the migration and the positioning can adjustable. The stent coating that decrease tissue ingrowth and good of the fluoroscopic visibility for stent deploy and adjusting. Minimal of the endo-leak. The indication of the esophageal stent also have both of benign and malignant. Benign condition is a stricture, perforation, and bleeding. For the malignant condition is an advanced primary esophageal cancer with or without ATE fistula or esophageal respiratory tract fistula, and metastatic cancer cause of combined with the esophageal obstruction. When we focus at the purpose of the esophageal stent. They have two purpose, like a permanent or or temporary. For permanent is aim to palliative care, and for decreased saliva pooling and regurgitation, restore natural nutritional route, and for temporary, temporary is to decrease the contamination and keep esophageal alignment, and it can, after the healing complete, the stent can be removed. This is just an example one for esophageal obstruction from cancer, and this is after the stent deployed, the lumen was open, maybe partially, not so complete. From NCCN guideline, they recommended for severe esophageal obstruction, the stent was recommended for severe. I mean, if the patient still feel like can drink the liquid diet or can eat some light soft or blended diet, the stent no have role for stent because of it maybe possibly for the stent migration. So you can wait for the patient have a more severity and until they cannot eat or drink only liquid only. It's feasible for push the stent. Yet for the ESGE guideline about the stent they mention about the fully or partial cover cell expandometric stent for palliative malignant dysphagia. And about the brachytherapy maybe have a role, but in Thailand it's not available anymore for brachytherapy. About the patient characteristic, this means of the survival rate of the patient or life expectancy rate of the patient. Because of the stent have the patency time around 4 to 6 months. If the patient have a life expectancy more than 6 months, the stent occlusion or stent complication may be occur after that. So you have to concern about it. When you put the stent in the patient have the life expectancy more than 1 year, after 6 months you have to think about to solve the stent problem. And the last one about the plastic stent, the ESGE guideline not recommend for the plastic stent because of it. The success rate is very low. I will mention later. Another point, the adverse event comparing between fully covered metric stent is have the major adverse event around 21% compared with the plastic or partial cover metric stent. The adverse event is a little bit less than the fully cover. The fully cover is the main problem is the easily to migration is a big problem. For the another adverse event is a reflux around 99.5%, the severe pain 8.7%, and bleeding 7.6%. And late adverse event is a reflux around 15%, and severe pain 15%, and ingrowth or overgrowth of the tissue means ingrowth or at the proximal or distal of the stent. I think this point is depends on time after stent placement. Another recommendation for malignant cases, the self-expandable metric stent is a strong recommendation for tracheoesophageal or bronchoesophageal fistula. And the second one is a double stent. Double stent means of the double layer stent. I will show you later. It's like for when you have a TE fistula and one stent, the one maybe first one maybe bronchial stent and or esophageal stent. If each one cannot completely occlude, the second one is have a role. Means if first is esophageal and cannot be complete occlude, you can consult a bronchiologist or trachologist for push the bronchial stent later. It means of the double stent. Okay, this video show the esophageal stent for case advanced esophageal cancer with TE fistula. When you perform the endoscopy in some case of the severe occlusion of the advanced esophageal cancer, sometimes it's difficult to identify the orifice of the fistula. And this case it shows the large of the orifice of the fistula, and you can put the endoscope to the bronchial and you can see the carina. It is a dangerous piece. We caution, and the patient have to take care about the airway during the operation very well. This is the stent, like a partial cover stent was pushed through the esophageal lumen over the guide wire under fluoroscope, and then the stent was deployed on the right hand side. Is a distal release, and the stent was deployed from distal to the proximal, and the marking that you see in the video is mean of the marking of the upper esophageal sphincter and lower esophageal sphincter. So the point of this case is to be avoid to put the stent over the sphincter. And then after the stent was deployed, you can compare with the previous. Before the stent insertion, the lumen was open, and the patient can maybe drink about liquid diet better and less of the aspiration, and the symptom is get better. However, it may be the symptom get better maybe in the limited time, around 4 to 6 months after this. Okay. For some case of if you have planned for surgery, the stent is maybe disturb your evaluation before operation. In some case, the mistake was occur after some doctor detect of the esophageal cancer with the obstruction, but not consult the surgeon yet, and the endoscopist push the stent first, and if the surgeon evaluate that the patient need to be receive the neoadjuvant chemoradiation, it's difficult to evaluate after neoadjuvant therapy. So ESG guideline also not recommend for bridging to surgery. So if the patient have the obstruction and you need time for before surgery, like a neoadjuvant, maybe 1.5 or 2 months, and the patient have a starvation, I think I recommend, and also ESG guideline recommend to do another like a PEG or gastrostomy for maintain the nutritional status. So the same for bridging surgery is not recommend and have a negative impact for that point. So please avoid and not do that, please. This is a case, for example, in this case, the patient was performed the stent before surgeon evaluation of the surgery. So no information after the push stent. I mean, the surgeon cannot evaluate the lesion after that, and so the surgery upfront was performed, and this is show that the stent was very adhere to the tumor very tight and very damage to the tumor surface. It may be like a trauma and difficult for pathologists also because of the inflammation of the surface also. And another point is like a bridging to surgery. The same is not recommended with for concurrent radiation because of, as I mentioned, it's difficult to evaluation after treatment. And about the suggest about the placement concurrent single dose brachytherapy. However, it's a weak recommendation. For benign disease, same is not recommended for first line of esophageal stricture, like after corrosive agent injection or another benign tumor, because of its very low rate of successful. We'll show you later. And for a benign condition, the temporary SEM may be have a role because of in some case after we dilate many times and sometimes it's a recurrent or refractory of stricture. So you can maybe alternate to use the SEM and maybe alternate back to dilatation after that. But the SEM is have to be fully covered and retrievable. Okay. For the benign stricture, the fully covered self-expandable stent success rate is only 24.2%. Another point for benign stricture or benign condition is a permanent stent is not recommended. Fully covered is recommended more than partial cover stent because of the partial cover have may adhere to the mucosa very well. So when you want to retrieve it, may be damaged and make an esophageal injury. So biodegradable is not recommended yet, and the last one is a plastic stent is not recommended. Another point is the temporary SEM is this is one of the most common practice in our hospital also. For the fistula or esophageal injury or perforation in the stable case or contraindication for surgery, the temporary SEM is have a role for cure the leakage of the esophagus and also for maybe for fistula for fistula because of the sometimes patient have a pneumonia after fistula. You have to diversion and maintain the recovery from pneumonia and make the operation after that. Okay, in the case of leakage, the time for push the stent have to as soon as possible, and the sometimes the leakage have another modality for treatment like a endo-vacuum therapy. I will show you later. Okay, for that kind of the indication, the success rate is higher than the benign stricture. The overall success around 76.8%. This show the DIY endo-vacuum therapy for case of leakage. This is made from an NG tube with a sponge coverage at the tip of NG tube. The principle is when you have the pocket of the perforation and contamination, the sponge on endo-vacuum maybe will be like a decontamination at the pocket and promote of the granulation tissue and blood supply. And the stent will maintain the lumen and like a function as a conversion to bypass the saliva and the water liquid drinking to the stomach. Okay, this video shows esophageal in case of the esophageal perforation after operation, like a duplication cyst of the esophagus, and after fail of the operative repair of the perforation 2 times. So the patient very exhausted and malnutrition, and endo-vacuum therapy was considered with the esophageal stent combined with esophageal stent. This is a pocket of the perforation, and you can see pneumomesinum and really high level of the pleural effusion on the left lung. Okay, and the procedure was designed because of the patient they was underwent the operation after perforation 2 times, so it's very difficult to correct by operation again. This is a pocket of the perforation. You can see the ICD tube inside, and another pocket to the left pleura. So this is a very severe one, as in my experience. So we try to use the endo-vacuum therapy by first with preparing of the endo-vacuum by use the sponge and the NG tube. Because of this device have to change every 3 or 4 days. So this DIY is a very low cost. I think it may be around 100 baht I think, by DIY. And the esophageal stent placement, we use a fully cover. And after each time, each period, after we follow the pocket with overgrowth of the cannulation as well, and around 5 to 7 times the pocket already closed, and we remove the stent, and we observe again at the pocket side. Here is the cannulation already fulfilled in the perforation space. Okay, I will skip this one. And my technique is you have to like marking at the 4 point. First is the upper esophageal sphincter, and the second one is the proximal of the lesion and distal of the lesion, and the lower esophageal sphincter. Because of your stent have to not exceed than upper and lower esophageal sphincter, and have to cover at the lesion as well. Okay, the last video I will show the demonstration of the esophageal, many kind of the esophageal stent that available nowadays. The esophageal stent have in this model I will show you. The first one is a lesion at the lower, near of the lower esophageal sphincter. So the stent have to use like a anti-reflux stent. This is show the anti-reflux stent is that distal release and to cover the distal lesion and it over the esophageal sphincter. The sleeve at the distal part will protection of the reflux as well. And the second one is like a distal release of the lesion. It proper for lesion at the mid-thoracic esophagus. And okay, and the last one I will show you this. You can deploy the stent through the EG junction and pull it back when you almost complete to adjust the location properly. Okay, and can close the example of a fistula lesion. Okay. And the last one is a proximal release. Proximal release is proper for the proximal lesions such as a cervical or upper thoracic. On the right hand side, the cervical type of the esophageal stent is a special type. Okay, I will skip this. Okay. I will skip to the conclusion because of I think time is over. The MRI, you can do the MRI during after you push the stem because of it not do harm and maybe increase of some temperature but not hazard for the patient. In my conclusion, the esophageal stent is feasible for both malignant and benign condition. Its appropriate indication is the key point to success, and the high clinical success rate for malignant stricture, clinical success almost until 80 to 90%, and low clinical success for benign stricture. In less severe early complication, it means the stent is very safe. Okay, and one-day surgery is a management may be considered for individual patient and condition. Okay, I will skip this. Thank you very much for your attention.
Thank you very much, Dr. Jirawat. So let's move on to the next speaker. You will see that in the morning we do the diagnostic, the early cancer, but in this section we focus on some treatment for the laparoscopic and the endoscopic treatment, and to help the patient to better outcome. So the next speaker will be the Professor Suthep Udomsawaengsup. He is the Professor of Surgery in King Chulalongkorn University, and he is well-known speaker, and he is the yeah. So please welcome Dr. Suthep. Yeah.
Thank you, Kanokan. Thank you for being a course director, putting everything together. And also, thank you very much. Thank you very much, Jirawat, for giving us an overview and also some techniques to help the patient. So as Gadoka has been mentioned, we try to cure the disease by doing early cases, but unfortunately we're still having some case who may need the advanced or end stage of diseases that we may need to treat the patient from their suffering. So standing, it's very nice, and that's a technique that should be equipped with yourself. But in some situation, we might need to have some procedure. So for you tomorrow, you're staying next to my university. So this is Chulalongkorn University. Please take advantage of going early in the morning, 6 o'clock, for a run in Chulalongkorn University tomorrow. As well as the park, Lumpini Park is nearby, so get your shoe. If you don't have one tonight, the department store is still available for you to find one or to join that part. King Chulalongkorn Memorial Hospital, we have the old, very old, more than 100 years building is also the new building, so please take advantage. This is the Department of Surgery, the Faculty of Medicine, which right now it's 77 years, and also the Chula Minimal Invasive Surgery Center, which you're gonna experience tomorrow. So as mentioned, the technique of stenting, it's very important to get the patient into the quality of life. But in some situations, especially for those who have very advanced intraperitoneal cancer, that multiple obstruction is happening. So I think how to deal with the quality, we need to drain those content out and give the patient the best care. That is what we gonna do. I know that the NG2 will be have a function, but they also have so many concerns about NG2. So let's see how I do it with the endoscopic PTEC. So actually, it's a percutaneous and transesophageal tubing. So this is the malignant that we might see. And so NG2 is one of the choice, but actually they're also having several complications. So PTEC actually started by Professor Oishi from Japan and Bipan Chan, who popularized this technique, and I also learned from both of them. But the limitation is that this is the tubing that will be lined in the most dependent part of the stomach, so it's allowing the drainage to be efficiency. One of the limitations is that you have to have a PTEC kit available in Japan, and I'll try to have it available in Thailand, but the number of the market is not that big, so it's not available. So then my talk will be covering the principle and the technique that I've been developed to be available in Thailand or in any places that you don't have a kit. So that the kits and the other side is the technique equipment that you might have already in your theater. You have the PCN dilator from your nephrologist, urologist, and also folic catheter. So I imitate those techniques by using the folic catheter balloon. This is a balloon from the folic catheter. But what different was that? The rupture-free balloon, you can puncture the balloon without any problem, but for the folic catheter, it's going to be burst after being punched, so that's the problem. So we try several techniques. Finally, we called it modified technique. And the thing is that at the cervical part, there are several vital structures you need to be familiar with. So we use ultrasound to demonstrate those vessels and esophagus, trachea, so that you have to be familiar with. Then this is the technique comparing the standard one and the modified with using folic catheter. So you have to have the fluoroscopy to identify the balloon. Outside you have the ultrasound, the probe to find the balloon, and you have the access by the needle puncture into the balloon. So that's the technique. This is what it is. So after puncturing, accessing into the balloon, so you can introduce the catheter. The catheter will be going into the stomach, so that's the technique. You can see that both sides. So the technique gonna be similar. Then you dilate it. This access will be dilated, and you put the catheter in. So this will be giving the patient more comfortable without any tubing from nose, from mouth, so that it is. So let's see. This is a pure off catheter that you can introduce the catheter in to lie in the stomach and the fundus. And how this is actually the video will show the burst of the Foley catheter, which if you have a good experience, you might have the needle still located in the intraluminal mostly, you will lose the access right away. So then what we have done after having some experience is that we use this called endoscopic PTEG, which similarly to what you are doing for the PEG tube. So that's a technique, but essentially you have to have a skill to demonstrate the vital structure. This is very important. So this is all the equipment that you might have in your theater. Put the scope down, have a scope demonstrate. You have the finger indentation, and then you can see from inside the ultrasound to get the accessing path into the esophagus without any injury to vital structure. And then same thing, we introduce the needle directly under direct vision from the scope. So this is our technique. This is a technique that we adopted. So you can see that, then we can introduce the catheter in. So I'm going to show you the video. There are some tip and technique that you might need to apply, because when you introduce the catheter in, sometimes it might have some, dislodgement right away if you don't have a good technique. Let me share to you. I want to go to the technique quickly with the video. This is the PCN dilator. You can see that directly into the esophagus. When you point, you dilate slowly, introducing into the epigastric part. So that's the techniques, and it's going to be using like this. So ladies and gentlemen, this is the technique Archana has been doing this video, but I want to go to this video, which we just have it this year. So let's see how we're going to do the technique.
Endoscopic assisted percutaneous transesophageal gastrostomy. A safe and feasible alternative technique for decompression in advanced malignant bowel obstruction. A 47-year-old female with a known case of recurrent fallopian tube cancer underwent multiple operations during 2 years of treatment. During the follow-up, a CT whole abdomen revealed peritoneal metastasis with overall stable despite multiple chemotherapy regimens. The patient made the decision to discontinue chemotherapy and received palliative treatment. Last admission, the patient presented with multilevel small bowel obstruction due to peritoneal carcinomatosis as shown in CT scan, which required lifelong gastric tube decompression. Equipments: Medicut number 18, guide wire, PCN dilators number 8 to 16 French with pusher. NG tube number 16. Ultrasound and gastroscope. Following the administration of general anesthesia, the patient was placed in supine position with neck extension and facing right. The procedure commences with the ultrasound-guided INS ion area at left cervical area with beware of surrounding structures as shown in pictures.
The vein will be compressible.
The
So
skin
as
was painted
demonstrated.
and draped and 5 mm incision was made at left cervical area. The puncture is made into the esophagus using a Medicut insertion of a gastroscope into the cervical esophagus. Subsequently, a guide wire is passed through the needle and into the esophagus. Tract dilators ranging from 8 to 12 French are advanced over the guide wire.
The dilator bigger than 12 millimeter, you need to have the pusher.
Then exchange guide wire with pusher.
So the orange catheter
Followed
down
by
there is the
14 to
pusher.
16 French dilators over pusher.
why would you need to switch to the pusher? Because the lumen actually will be not to, it will be difficult to introduce into the esophagus without the pusher. So that's why we have to switch to the pusher.
To establish the passage from the esophagus to the stomach, a nasogastric tube is introduced through the pusher.
Actually, the pusher, the link of the pusher, it's not able to, get out at the end of the NG tube. That's why we have to put it out at the side wall of the actually NG tube. So you can see that it will be, two tubing.
Confirmation of proper placement is achieved via gastroscopy.
We aim to put the drainage into the fundus of the stomach to ensure the efficiency of the drainage. So that will be the conclusion of the procedure. Then you need to, getting the technique, endoscopic technique, to remove the pusher.
And the tube is secured by suturing it to the skin of the neck.
So I think this is an example of
in our
using
patient,
endoscopy
EPTG proved to be safe and effective as an alternative technique in achieving palliation or gastrointestinal decompression, with no reported complication. EPTEG, which serves as a safe and effective alternative technique to PTEG for gastrointestinal decompression in patients who are not suitable candidates for standard enteral access. Appropriate patient selection is crucial for maximizing the benefits of EPTEG.
So I think that's the technique that we develop in our center. Thank you very much, Patarasai, sitting over there preparing the video for us. So I think this is the example. Our next session, I think, is going to be emphasizing that endoscopy should be in our hands to empower ourselves to help the patient. Thank you very much.
Thank you very much. As the surgeon, we will be the endoscopist, we will be the interventionist. So for the last session in the morning, so I will invite Dr. Jirawat again to present the other endoscopic treatment for the push PEG, please.
Thank you very much. I think the PTEC by Dr. Professor Suthep is really useful also for particular case of the advanced stage cancer. And I think another indication is after esophagectomy patient. If after esophagectomy and the patient have a recurrent tumor, I have no place to put another new of the enteral nutrition. So PTEC is a really good choice. So I will introduce you about the ordinary technique of the GI access for like a malignant patient. Okay, for the indication for enteral route access is for like a functional dysphagia, as you can familiar with the stroke and Alzheimer and motor dysfunction. Another is a mechanical obstruction like a tumor, advanced stage cancer, pre and post of the upper GI cancer treatment, and after and maybe pre-operative and after or pre-radiation. And the last one is for palliative treatment, like a gastric drainage. For the patient, cancer patient, the nutrition is very important from the anti-cancer treatment, during treatment, and the post-treatment. For palliative care is also very important. Because of the patient have cancer, they have a condition of the malnourished, malnutrition, dehydration, and sometimes aspiration and infection. So for SPEN guideline, the recommendation of enteral nutrition is a priority, superior than parenteral nutrition in the issue. Many issue different. Comparing between enteral and parenteral nutrition, many study and the meta-analysis show in the same way of the trend of the different comparing of the few of the infection of the enteral nutrition, fewer infection, and reduce cost and earlier gut function and reduce length of hospital stay. Every paper uh, in the same result. And another point of the parenteral nutrition, if you have a postpone of the starvation in the gut of the patient, will be occur of the bacterial translocation or gut sepsis, and it make the patient have the infection and another complication of during treatment. The route of the enteral route feeding. In Jirawat Hospital, during 5 years, we have 1,500 cases. And nowadays, the majority of the enteral route is a peg push technique. Another is a NJ pull peg, and another kind of enteral route. First, in the surgical department, mainly is a peg push technique, around 7% among 1,000 patients. And the most case of is a malignant, around 70%. As you know, the modality of the feeding tube from the conventional like a NG tube, open gastrostomy, silicone tube of gastrostomy, peg pull technique, and the latest one is a peg push technique. Is I think it's also available in worldwide, and each one is maybe different of the indication and condition. Like when the patient have the obstruction of the from the oropharynx until EG junction, the modality that's feasible is open gastrostomy and peg push technique. And if the patient have obstruction at the post-pyloric obstruction, the jejunal feeding is have a role for feeding. So you have to know the contraindication for enteral route access, like a gut obstruction, the short bowel syndrome, ileus, and gastroparesis or dysfunction. The relative contraindication is a septicemia, hemodynamic instability, coagulopathy, abdominal wall infection, massive carcinomatosis peritoniae. The common type of PEG nowadays worldwide, I think we have only two kind of PEG, like a PEG pull technique and PEG push technique. The PEG push technique have another name like a low profile and skill level. And in Thailand, we have available two kind of PEG push technique, like a four-wing type and balloon type. This video will show you the technique of the PEG push technique. Sorry. Okay. For the patient have the carcinoma that obstruction the esophagus, we use the small size or extrapedetic endoscopy, diameter around 5.9 millimeter. And if the tumor have a very severe stricture, like you cannot push the scope through, in my practice, I use the subauricular dilator until 8 millimeter. It's safety. And if you can push the scope past, you can do the peg push technique without tumor seating. So at first you have to find the location at the anterior gastric body and injection the local anesthesia, and then the needle that you use to push the anesthesia, you can measure the depth of abdominal wall include with the gastric wall. So you have to select the length of the peg push technique by plus the thickness plus 1 centimeter or 1.5 centimeter. And next step is to suture the gastric mucosa or gastric wall to hanging gastric wall to attach with the abdominal wall. The suture device is provided with the introducer kit of the PEG. So you have to make a suture parallel to suture by the 2-0 nylon material, and then make the incision at the center of the location around 2 centimeter, and then put the Gelco or Medicut needle to prevent of the gastric wall injury opposite side, and guide wire was insertion under endoscopic view. After guide wire insert, the dilator it was dilated up to 24 French, and the latest version have the silicone sleeve and then PEG push technique was inserted at the through the silicone sleeve and retrievable of the silicone tube. The PEG was deployed and secured in the place in the stomach. And this is my technique to bleeding prevention by use of silver nitrate cauterization. This kind of PEG has quite have a long period for use. I use for 1.5 year or 2 years. Can it still function? This location, and this is after the operation. This PEG is seem minimal and very low of the disturb of the daily life of the patient. This point is the PEG length. You have to select the PEG 1 or 1.5 centimeter longer than the abdominal wall thickness to caution or to avoid the Barry bumper syndrome. However, the PEG have also major and minor complications. The major complications such as we have one case of the early dislodge of the pull PEG technique because of it not have a suture. So be careful after operation. You have to like a pressure dressing and keep the bumper to attach to the gastric wall and like a tight attach of the abdominal wall. I think this case is not do it so good, but the bumper is like a floating and make the gastric was dislodged down from the abdominal wall. So the patient come to hospital again after operation around few days with a peritonitis. And the severe infection in Jirawat Hospital have one experience of this case, severe like a necrotizing fasciitis of abdominal wall. So please please detection of the early infection. If some patient have early redness or sign of infection, please give antibiotics earlier to avoid the severe complication. The tumor migration have a only report from many institutes. Almost all of the report is related with the pull technique, and the patient have the oropharyngeal cancer. So please avoid the pull technique with oropharyngeal cancer. Please do the push technique or open gastrostomy. And this last one is a wrong puncture site. Is one of the amazing case. I don't know how the the endoscopists do that. I don't know, but the patient have a diarrhea after that, and some case have a peritonitis after this event occur. So maybe need the operation for correct this condition. Okay, the minor I will move it fast. Okay, and the major of the minor complication like a hypergranulation, Barry bumper syndrome, tube obstruction, wound pain, maceration, tube dislodge, and minor bleeding. This slide shows you that the PEG push technique, even though you did the PEG push technique for the patient prepare for esophagectomy, you can use the stomach. After before operation, you can remove the PEG push technique for 7 days, and you can use the stomach for gastric tube reconstruction for esophagectomy, because it really minimize of the area of injury, so no problem. Also in the NCCN guideline, you can notice that nowadays the NCCN guideline recommend that gastrostomy or PEG before esophageal surgery also. Okay, I will show the cost of the PEG. I think you also interesting in the PEG, but you please consider the cost right now. The PEG kit for introducing kit for Thai baht is around to 20,000 baht, and for the PEG tube only around this slide it may be not updated, around 8,000 baht right now, and for foreigner it costs around $900. In my conclusion, nutritional status is influence cancer treatment outcome. Nutritional assessment and appropriate intervention is necessary. Enteral feeding is optimal nutritional route. PEG and push PEG is minimally invasive enteral feeding route. Thank you very much for your attention.
Thank you very much, Professor Jirawat. Any comment from the floor? We have a short of time, but we still have the question from the online. So the online who they have a question about what Dr. Hon-Chi used to inject the submucosal layer. Yeah.
Thank you. So actually, it's just usual saline. We add a little bit of indigo carmine to make it colorful, a little bit bluish in color. And in one of the case I demonstrated, I also add in ICG because it will help me in the laparoscopic view, because sometimes the blue color is too light. And the ICG, I change the button, it lights up like a bubble. So it's quite nice.
Oh, thank you very much. And any question? For me, I think maybe the trainee would want to know about which location of tumor which is difficult to do the legs, because if they do in the first or the second case, maybe they need to select the case, right? So what is your recommend?
Thank you for the question. So basically, personally, what I would do is first you find the best procedure for the patient first. So we do it for a fundus lesion because it's easily wedged. So in that case, you can do a wedge resection in 30 minutes. So I won't do a spend 1 hour, 2 hours just to dissect. But maybe smaller lesions, but they are in tricky locations, such as maybe in the antrum, near the pylorus, in the cardia, where you really cannot do a simple wedge. But those lesions has to be maybe smaller in size if you're beginners, and you have to check with your endoscope whether you can access the lesion easily. Those are maybe some of the tricks that I would check, or I would advise for beginners trying to start a LEX procedure. And if you have some experience in ESD, it will help as well.
So any comment from the Dr. Prasit or Dr. Suthep or Dr. Asim?
So, thank you very much. I like the technique of using the introducer pack, and I have seen that in your right now you applying majority of the push instead of the pull. So what make you change your practice?
Thank you very much, Professor Suthep. One is our concern about because of majority case is a tumor obstruction, so we avoid the pull technique. And another point is we in my hospital some patient can reimburse of the price of the PEG, so it's like a patient can afford more and more. So majority is so push PEG nowadays.
For any particular condition of the patient?
Until now, the pull PEG is like very less number of use because of we feel of the benefit of the push technique. We feel more confidence because of the push technique have the suture. So the suture is a make me like a feel like a to avoid the complication like I show in the picture. It's a dislodge, early dislodge. So many colleagues and now majority of the PEG like underwent is surgery. In GI medicine is may drain every case to the surgery also. So in the surgeon sense, the suture is more confidence for avoid the complication. Thank you very much.
So thank you very much. I fully agree that for malignancy, especially head and neck cancer, that you avoid the chance of a tumor sitting on the tract. So that's very perfect indication. But I think in generally most of gastroenterologists, including most of the surgeon, will still doing the pull technique. The pull technique will be be done within a very comfortable and very short time. But anyway, introducing and ensuring the placement of the pushback is also very nice. Thank you very much.
Thank you very much.
So thank you very much for all speakers and the trainee in on-site and online to be with us for today. So the next will be, I will invite Professor Michael Lee for the closing online session.
Okay, well, I'm glad you enjoyed this morning's session. Been a wide variety of interesting topics. I hope you gain knowledge from this morning's session. Thank you for attending on the online.
I would like to invite Dr. Suthep for the closing speech. Please welcome.
Thank you very much, especially for those who are being joined us online, and hopefully next opportunity will be having you with us here at T-TEC as well as at Chulalongkorn University. So, but for those who are staying with us here, we're going to have lunch, and for sure in the afternoon will be a very nice experience for you to learn to apply endoscopic into the situation that would help you. Please join us until tomorrow evening. Thank you very much.
Thank you, Dr. Suthep. And next, I would like to invite Dr. Asim Shabir to deliver and closing speech. Please welcome.
Thank you very much. I think, many people would agree when you come to a workshop, you really want to work, right? So I think we have worked. It's now your time to shop around and work when you go to the lab. So I think these, as you've seen in endoscopy, a lot of knowledge that has been shared is basic knowledge, all right? And a lot of things that you would do, you may think are basic, and some of them would be advanced in the lab. But this is how you train to deliver the best to your patients without having to compromise the care of your patient. So if I were you, and when I was you, we made best of what these opportunities provide. Okay, some of you may never have done an endoscopy. Others of you may have done a total mucosal resection of the stomach. All right, so the expertise vary, right? So suit yourself, and we will basically help you through this. And that's our role here, to take you through what you can't, and hopefully every step is a step towards advancement. Every step is towards a new future, a brighter way to look at things, yeah? And hopefully this will help you understand what truly endoscopic laparoscopic surgery is, okay? So explore your potential and do the best out in the lunchtime. And thank you very much for a great morning session.